Welcome to the SCR Connections April webinar. Thank you everyone for joining us. It is my pleasure to introduce our guest speaker, Dr. Janet Miles. Dr. Miles is a pathologist with Propath LLC based in Dallas, Texas, and serves as the current laboratory medical director for John Peter Smith Health Network in Fort Worth, Texas. She received her medical degree from the University of Missouri, Kansas City, and completed residency and fellowship training at the Cleveland Clinic Foundation. Dr. Miles has 27 years of experience in the clinical laboratory field and specializes in clinical laboratory administration, regulatory compliance, and quality management. She is board certified in anatomic and clinical pathology and neuropathology. She is a past recipient of the Kansas City Business Journal Women Who Mean Business and a fellow of the American College of Pathologists. We are also pleased to have Dr. Miles here in the SCR office with us this morning. I'm now going to hand over control and let her get started. Welcome.
Good morning, everyone, and thank you so much for joining us. I know everyone is very busy, and I appreciate having a bit of your morning. A topic of great interest to me is overdiagnosis, but since I'm a laboratorian, I'm really specifically focusing today on why too many lab tests actually may be bad for your health. As Brian told you, I am the medical director at John Peter Smith Health Network in Fort Worth, Texas. In Fort Worth, we're big, very proud owners of our Longhorns, as you see on the left lower-hand corner of your screen. On the right-hand side, this is just my crew at JPS. JPS is the only level 1 trauma center in Tarrant County and is the county hospital serving as a safety net facility for Tarrant County in Fort Worth, Texas. And that's just my crew. We're a bunch of lab rats over at JPS. Overdiagnosis, my topic today, is really an emerging trend that has just really started getting the attention of healthcare providers starting around 2012. In the Archives of Internal Medicine, it was called an overdiagnosis of disease that has created a modern epidemic. Much of my talk today is based on the book by Dr. Gilbert Welch called Overdiagnosed. I highly recommend this reference for anyone who has any further interest in the topic. Seeking Sickness is another book that I highly recommend. But as you'll note, there's a number of large organizations, including the American Board of Internal Medicine Foundation, the American Society of Clinical Pathologists, the American Association of Radiologists, and the British Medical Journal, who have all started getting very interested in this topic. So let's start out by saying, what is overdiagnosis? I find this fascinating. This is a Facebook survey from 2014 in which 40 surveys respondents stated what they thought was the definition of overdiagnosis. These 45 respondents were roughly equal divided between healthcare and non-healthcare professionals, and you can see from the chart on your right-hand side that they had significant differences in what they thought was overdiagnosis. In the healthcare professionals, the most common response was a diagnosis of a condition which never led to symptoms. Interestingly, though, 63% of non-healthcare professionals had no idea what overdiagnosis meant. And then the rest of folks sort of split around inadequate, misapplied diagnostic criteria, an unnecessary diagnosis, or an inappropriate diagnosis. So this begs the question, what actually is overdiagnosis? I like this definition, again, from Dr. Gilbert Welch. Overdiagnosis is defined as ascribing a disease or condition to a person that will never cause them symptoms or death. I guess the next thing we need to talk about is why overdiagnosis is important. Why do we think it could potentially cause harm to patients? Basically, overdiagnosis is a condition that can lead to the treatment of diseases that would not normally cause symptoms or death. Almost all treatments have the potential to cause harm: unnecessary surgeries, excessively aggressive treatments, medication side effects, and just the emotional distress of being labeled with a condition that potentially will never cause you harm or even your death can be a very significant byproduct of overdiagnosis. So let's take an example, the harm from too much diagnosis. And in the news recently, I hope many of you are familiar with this topic because it was on the evening news with Brian Williams, and a lot of other local news outlets picked up this story. This is the relationship between cholesterol, statin treatment, and side effects. And for those of you who don't know what a statin is a class of drugs that is used to lower cholesterol. And there has been a study done looking at if 100 patients are diagnosed with barely abnormal cholesterol levels, that is, cholesterol levels that are just a little bit above normal, and they are treated for their lifetime, 8 of those people will be winners. In other words, 8 of those 100 people that were treated with very minimal elevations in cholesterol will be saved from a first major heart event. 14 of those people, however, who took the statins for minimally elevated cholesterol are going to go ahead and have a heart attack despite treatment. So the treatment didn't help, didn't do them any good. What's most astounding to me is that this group of minimally elevated cholesterol folks who are treated with statins, 78 out of 100 of them, that's 78%, the treatment wouldn't help them because they were never going to have a heart event. So many of you might say to yourself, well, that's no problem. So I took the drug and I spent a little bit more money than I needed to, but I'm a loser in the sense that I spent all the money for the drug, but I didn't have an event and I stayed healthy. This is where the problem comes in. There is significant side effects associated with statin therapy, and the list that I have on the slide in front of you is just a partial listing of those. The most severe of these are really the ones that are on the list: muscle pain and weakness, muscle damage, the evolution of diabetes, liver damage, mental confusion. I sound like an advertisement on the TV when you're watching the news at night and you see these advertisements come on for drugs, and they say, may cause muscle pain or weakness, muscle damage, increased blood sugar, liver damage, mental confusion, or memory loss, nausea, vomiting, diarrhea, including and up to death. And I know you've all heard these commercials, and I bring it up mostly because I want to really emphasize that virtually there is no drug treatment available that does not have the potential to cause some side effect or the potential to cause some level of harm. With regards to statins, this is so substantial that the FDA issued a safety warning in May 2016 regarding statins. All statins now have safety warnings on them due to the risk of memory loss, diabetes, and muscle pain, and this is just an example of the kind of labeling that must now be put on statins. So statins are a really great example of where overdiagnosis can lead to the use of a drug that has the potential to cause significant harm. So let's talk about this. Doctors don't go into medicine to cause harm. Certainly we want to help people and we want to make them well. So why do we have overdiagnosis? What is driving this phenomenon? I want to look at a couple of assumptions that make overdiagnosis occur. The first one of these is the assumption around promoting health. There is an assumption that early treatment reduces or eliminates disease. That seems to be logical, doesn't it? It seems to be true. But really, is it true? If we look at hypertension treatment, again, this is from Welch's 2011 publication, there is a study looking at various levels of hypertension. Hypertension is high blood pressure. High blood pressure can be defined by the two numbers, the upper number and the lower number. So a normal blood pressure, for example, is 120 upper number over 80. The 120 is systolic, the 80 is diastolic. This study was looking at that lower number and divided people with hypertension into 4 different classifications: very mild, mild, moderate, or severe. And then what they did is they looked at the outcomes of these people who had treatment versus no treatment. So if you look at the top line where it says severe diastolic blood pressures of 115 to 129, if the patients had no treatment with the blood pressure at this level, which was considered severe, 80% of them would have an adverse event in 5 years. So the benefit of treatment for these people is quite high. 72% of people who are treated in this category benefit. The number needed to treat, the number of people you needed to treat before you saw a positive benefit was only 1.4. Let's go down to the bottom of this chart and look at very mild diastolic blood pressures. This is where the blood pressures are in a low range of 90 to 100. Of those people who received no treatment, only 9% had an adverse outcome. I'll say that again. Not treating people with very mild blood pressure, only 9% of them had a poor outcome. The benefit was quite low. In other words, only 6% of people benefited from treatment. You needed to treat 18 people in this category before you got a benefit from one. So this chart is a little bit busy, but it shows you that treating diseases depends on how severe the disease is in terms of the positive benefit. Let's look at that in a different way. This is a chart which shows mild to severe disease on the x-axis and the treatment benefit on the y-axis. And it really is a fairly linear relationship that the more severe the disease is, the more likely you will benefit from treatment. Conversely, the milder the form of disease is, the less likely treatment will provide you any benefit at all. And I want you to keep this in your mind as we go through this talk today, because it is really very important that treatment of diseases definitely depends on how severe the disease is. So let's go back to our assumption. Treatment of early disease actually has a very limited effect. Treatment of early diseases has limited benefit, potentially making people sick in the pursuit of health. And the little cartoon in front of you says, scientists now lack sleep, says the lack of sleep is linked to chronic health problems, including Alzheimer's disease. And obviously our little friend here is not sleeping and is now worried and distressed over the fact that he's not sleeping and therefore could get Alzheimer's disease, and decides he should probably stay up and research that even more. So let's look at a second driver of overdiagnosis. Screening for cancer. Everyone knows about screening for cancer. Mammograms have been in the news. PSA actually is just in the news again this week. And the assumption has always been that the earlier we can identify cancer, the more likely we will improve survival. Well, that's an assumption, but is it true? So let's look at some data around this. There is evidence for overdiagnosis in screening of cancer. This is a chart looking at prostate cancer. It goes from 1975 to 2007, and the sort of greenish line shows you the number of deaths related to prostate cancer over that very long period of time. The diagnosis of prostate cancer is represented by the dark red line, and you see a very substantial peak starting somewhere around 1985, and the peak goes up rather dramatically. And that coincides with very widespread use of prostate-specific antigen or PSA screening in the general population. So what this chart shows you is we are diagnosing prostate cancer at a significantly increased rate, but we have not changed the deaths from prostate cancer virtually at all. Here's another one, same sort of chart. This is on thyroid cancer. Again, this is looking at mortality or death from thyroid cancer, which are the hashed lines at the bottom, and then the solid lines above it is actually the diagnosis of thyroid cancer. And again, we're seeing a disconnect. We're diagnosing a lot more thyroid cancer, and yet we are not impacting survival in any meaningful way. And then finally, this is a third example for you around melanoma. Melanoma is a skin cancer, and it is related to sun exposure. The bottom line is really essentially a flat line, and those are the people who have died from melanoma. The top lines, the blue lines at the top, which are hashed, are those people who have actually been diagnosed with melanoma. So once again, we're seeing a very significant increase in the diagnosis of the disease, and yet we have virtually no impact on the survival. This data really does suggest that perhaps we are overdiagnosing cancers, and even though we are diagnosing some of them at an earlier stage, we are not improving survival. So the assumptions of finding some cancers early, and I do say some cancers because this is not true for all cancers, finding some cancers early does in fact not lead to improved survival, potentially making people sick in the pursuit of health. And I love this cartoon because it says perfectly healthy but worried about cancer, head-to-toe cancer screening, next exit. And the gentleman is wondering if they actually have a drive-through option. But of course, this is a classic case for potential overdiagnosis because we are potentially screening diseases which will not avoid harm or cause any death in this patient. Finally, let's look at the driver of overdiagnosis around avoiding litigation. Many of our audience members are likely also familiar with this topic because it's been in the news around Obamacare and the Affordable Health Care Act and the overuse of laboratory testing and radiologic testing. The suggestion has always been that medical malpractice claims leads to more testing. But again, is that really true? So let's look at some data from the National Practitioner Data Bank. And this is a very busy slide, but really I want to call your attention to the pie chart. The pie chart on the left upper corner is the percentage of claims by allegation group. And the largest group, which is the blue part of the pie chart, is a diagnosis related. What this pie chart is telling you is that the majority, nearly or over 50% of medical malpractice claims are in some way related to a diagnosis. If you then go to the pie chart at the top right, this breaks it out in the diagnosis-related allegation category, and the largest category here is failure to diagnose. The second largest is a delay in diagnosis. We can look at this another way. This is a failure to diagnose slide, and it's showing, again, from the National Practitioner Data Bank, the proportion of the most common errors over time. Again, the top error related to diagnosis is a failure to diagnose. There's also delay in diagnosis, wrong diagnosis, improper management and performance, but the failure to diagnose trumps all. That is the most common reason physicians will fail to diagnose. Laboratory tests account for 80% of the medical record, and the majority of diagnostic errors involve laboratory testing. Litigation is, in fact, a huge driver for defensive medicine and increased testing. Again, we see in this pie chart 44% of errors diagnostically occur during the testing phase. The testing phase is defined as order, reporting, and follow-up of lab results. So this data does, in fact, suggest that medical malpractice claims are leading to defensive medicine. Said another way, the defensive medicine is, in order to avoid a medical malpractice suit, does in fact increase laboratory testing, potentially making people sick in the pursuit of health. And this doctor says offhand, I say you're suffering from an arrow through your head, but just to play it safe, I'm going to order a bunch of tests. So let's move on and talk about the laboratory role in overdiagnosis. There's a lot of areas I could talk about here, but really I'm going to focus on three areas, and that is screening laboratory tests, which include limitations of those tests, reference ranges for screening tests, changing the threshold for a disease state or condition, and the utilization of tests with limited or no clinical efficacy. Screening laboratory tests, what are they? First of all, let's talk about what they are. A screening laboratory test is a test which is used to identify people who are at increased risk for disease but don't actually have symptoms or signs related to that disease. Now, that should be a red flag for you, because doesn't that sound a lot like the definition for overdiagnosis? We are looking for people who have no disease, no signs or symptoms of that disease, and we are looking for them. And we are looking for them because we want to keep them from dying from cancer, or we want to treat them early. Now, we've already talked about the fact that that is inherently flawed thinking because of the diagnosis of overdiagnosis. In fact, is exactly that. We're looking for people to treat before they actually are going to have harm from their disease. So these two things are quite interrelated. However, screening tests can be useful in specific clinical instances. The trick is how to know when to use them or not. Screening tests can also be used as an early aid when the diagnosis is not clear from the presenting signs and symptoms. And unfortunately, very often screening laboratory tests are used indiscriminately as part of a routine health visit. I wonder how many members of our audience go in for their annual physical examination and you always end up getting lab tests. You may get something called a CBC, or complete medical count, or some sort of metabolic panel, which is called BMP or CMP. That's a basic metabolic panel or a comprehensive metabolic panel. These are tests that look at things like your liver enzymes, your glucose levels, electrolytes, etc. The men in our audience may have been screened for prostate-specific antigen, or PSA, as part of their routine health maintenance visit. I imagine many of you have had a lipid profile done at some point in your life. Lipid profiles are those that look at things like cholesterol and the LDL, the low-density lipoproteins. And then finally, many of us have been screened for diabetes using hemoglobin A1C or maybe just even glucose levels. So screening laboratory tests are often just routinely ordered as part of your routine health visit just because you're in there for a routine health visit and not necessarily based on symptoms, signs, complaints, or medical history. Why is that a problem, though? Why is that a problem that we would go ahead and screen for these tests? I mean, they're covered by your insurance in most cases. They don't really cost that much. Why is this an issue? The issue becomes that you need to understand what is the limitation of these screening tests. And here's where I need to get into a little bit of statistics and science. So bear with me, and I'll try to work through these next couple of slides with you. The ability of a laboratory test to accurately identify a person with disease is dependent on a number of statistical factors. These statistical factors are really dependent on how well the test performs. A lot of people have the misconception that a laboratory test is an absolute number. That is to say, we take a tube of blood from you and we put it in the laboratory and we put it on a piece of equipment that is going to analyze the blood and give you a numerical result. Many people, including physicians, are under the false assumption that that is an absolute result. In other words, many people assume if my glucose level is 120, well, that is my glucose level is 120. Most people don't understand that there is a performance issue around that test, that there is a circle of error around that test. The test performance is not that accurate. A level of 120 on glucose may actually represent 96 to 124. That level of error is acceptable to us in medicine because we understand that tests have sensitivity, specificity, and that those two things are dependent on prevalence. So let me back up a little bit again. The performance of tests depend on how accurately they will identify a person with disease. The performance of those tests are statistically represented by the things on your slide. Sensitivity is whether or not the test can detect a true positive result. In other words, sensitivity means you actually have the disease and the test detected it. Specificity of the test is a true negative performance characteristic. In other words, you don't have the disease and the test is negative. Sensitivity and specificity are inherent in the analytical performance of the test, and we certainly will not get into that this morning. However, sensitivity and specificity are also tied to something called prevalence. Prevalence means how much of the disease is in the population tested. All three of these factors, prevalence, sensitivity, and specificity, work together to determine whether a person actually has a disease predicted accurately by the test. This is all what's called predictive value. There is a positive and a negative predictive value around screening laboratory tests. Again, sensitivity, specificity, and prevalence work together to determine if a test will accurately predict whether a person has disease or not. The positive predictive value is the likelihood a test will correctly identify disease. The negative predictive value is a likelihood the test will correctly predict the absence of disease. At this point, my students are usually banging their head on the desk and saying, I'm totally lost, I have no idea what you're talking about. The sensitivity, specificity, prevalence stuff has got me completely confused. Now, some of you may be feeling that way. I often feel that way when I start talking about statistics. So let's look at a specific example. I hope this will illustrate the point I'm trying to make. This is a report from the MMWR Weekly, which is a report that comes out from the CDC. This particular case report is from June 2008. It's a true report. It really happened. The patient was a 35-year-old female who presented to her family physician with fevers, aches, chills, and sweating for 2 weeks. The family practitioner did a battery of screening tests on this patient. One of the tests was a Brucella antibody, and it tested positive. The patient, on the basis of this positive test result, was given a twice-daily antibiotic and told to take it for 6 weeks, 2 times a day. The patient, however, discontinued the antibiotic after a very short period of time due to drug side effects. Once again, remember, there are no drugs that exist on this planet that do not have some level of side effect. The state and county epidemiologists began an intensive search covering 3 states for the source of the Brucella organism that infected this 35-year-old female. However, they did some follow-up confirmatory testing, and it was negative. Well, in order to understand this, I need to deviate a bit and tell you a little bit about what is brucellosis. Brucellosis is a very uncommon disease in the U.S. The prevalence is only estimated to be 1.1%. That is, if we take 100 people, a little bit over 1 of them would potentially have Brucella. Brucella is caused by a bacteria which is found in cattle, sheep, goats, and swine. Most people, I would nearly say all people, who do not have contact with cattle, sheep, goats, or swine are highly unlikely to have this disease. It may be acquired by travel to an endemic area or by eating unpasteurized cheese. And the diagnosis is typically made by using serologic tests. What that means is a blood test for antibodies to the Brucella bacteria. So what went wrong in this case? Well, let me remind you, the prevalence of Brucella in the U.S. is 1.1%. The screening tests for Brucella have a specificity of 79 to 100%, which means they're really good at finding people who don't have the disease, and a sensitivity of 83 to 100%, which means they're actually pretty good at finding people who do have the disease. When you calculate the negative and positive predictive values, however, this is when you begin to see the effect of prevalence. I just told you the specificity and sensitivity of a Brucella test is really quite good. I mean, it's almost 100%. So it's really good. We consider that a really good laboratory test. It performs really well. Because Brucella has such a low prevalence in the population, it has a very strong negative predictive value. In other words, if the test is negative, I can feel 99.5% confident the patient doesn't have the disease. However, and here's where it gets complicated, if the patient actually tests positive, because the prevalence is so low, there's a very high likelihood that this positive result is in fact a false positive. So this test is useful for physicians in excluding disease and really quite useless in making the diagnosis, because positive predictive value of 36 to 43% is actually less accurate than flipping a coin. So a positive test doesn't really help you in this situation. Hopefully this has illustrated for you, and I'll take questions on this later because this is a little confusing when you first look at it. But this was intended to show you that uncommon or rare diseases with a low prevalence in the population tested have a high false positive rate, even when the test is a good test. Uncommon diseases can have a very high false positive rate. That's really what I want you to take out of this example. Let's talk about another characteristic of a screening laboratory test I think is really important for people to understand, and I don't think the general population understands this, and I know a lot of my clinician colleagues do not understand this. Laboratory tests have a reference range. That's the thing that you get on your laboratory report that'll say reference range 60 to 120, and if you fall in 60 to 120, you get a green sticker on your lab result, or you don't get a high-low, or you don't get some kind of a mark. You are within the reference range. You are considered normal. Well, where does the reference range come from? Because I don't know if you've ever noticed, but if you have one laboratory do tests for you and then have a second laboratory, the reference ranges are not the same, are they? They're different. If you go compare 2 different laboratories' reference ranges, they're often different. So where do we get this number from? Laboratories establish their reference ranges based on the population they serve. The reference range represents 95% of that normal population tested. What's on your slide is a graphical representation of a reference range. Everything between point A and B is 95% of the normal population. Between point A and B, you would be considered normal if your test results fell in that range. But wait a minute, there is 2.5% on the left side of point A and there's 2.5% on the right side of point B. What does that mean? What if I fall outside there? Reference ranges are a statistical manipulation of laboratory data. They include 95% of the population and consider them healthy or normal. Laboratory results that fall outside this healthy or normal reference range actually will show up abnormal as high or low as a test result, however, may in fact be a normal, healthy person. Let me say that another way. Laboratory results that fall in that 2.5% zone on either side of the healthy reference range population may or may not represent the presence of disease, because you may actually still be in that healthy population, you just were excluded statistically from it. So let's move on and talk about shifting disease thresholds. A threshold is a cutoff. It's a numerical value at which the test is considered abnormal or disease above the threshold and normal or without disease below the threshold. Well, where do these come from? Where does this cutoff come from? The cutoff comes from a consensus of experts in most situations. The experts are typically physicians, epidemiologists, researchers who are considered the experts in their field, and they get together and they literally go through the data and the literature and the research, and they decide where the cutoff should be. However, these experts have an inherent bias. These experts are all healthcare practitioners. I mean, we all went into healthcare, and those of you who are in healthcare are in it because you want to help people. You want to prevent disease. You want to save lives. Many of us have in our mind, I will prevent disease wherever I can, for prevention is preferable to cure. That is actually part of the Hippocratic Oath that all physicians take when they graduate medical school. So the bias that is in the consensus of experts is that if I expand the threshold for disease to capture all who might benefit from treatment, I will prevent the disease from occurring. So the experts who sit down to do these thresholds really are somewhat biased in that they want to keep expanding people who might benefit from treatment. But as we're going to see, that may be a problem because we've already seen that treating very early disease has a very limited benefit. And I'll get back to that in just a minute. So let me give you some examples of thresholds or cutoff values that have recently changed in laboratory results. Fasting blood sugar has changed for diabetes. The systolic and diastolic blood pressure cutoffs have changed for the diagnosis of hypertension or high blood pressure. Cholesterol, many of you may have seen this in the media. The level at which cholesterol is considered abnormal has dropped over years from 250 to 200 to 180, and that is for the diagnosis of hyperlipidemia or increased lipids. The bone density score, which is used to diagnose bone loss or osteoporosis in women, has also shifted in recent years. So what's the problem with that? Isn't it a good thing that we're changing the threshold? So we're trying to find more people who might have disease. We're trying to find more people who might benefit from treatment. Well, let's look at this. If we lower the threshold at which a person is considered diseased or with a condition, it increases the number of patients who are labeled with the disease, and it includes more people with the mildest form of the disease, potentially leading to overdiagnosis and treatment. This is graphically represented for you on your slide, where you see the bell-shaped curve, and in the red zone are the patients who would have been previously diagnosed as having disease with the old cutoff, and yet when the cutoff is shifted in the orange, we see that there's a significant number of patients who are now included as having disease and requiring treatment. In this example I provided you is cholesterol, where 240 used to be the cutoff, and now we've shifted it to 200. This is a very interesting chart, again, from Dr. Welch's book, Overdiagnosis, and it looks at Americans who are now considered diseased based on a changing or shifting threshold. The top line shows you diabetes. Fasting sugar cutoffs used to be 140. We've now shifted it to 126. Under the old definition, 11,697,000 people were considered to have diabetes based on a fasting sugar greater than 126. Under the new definition, it increased those cases by 1.7 million, roughly. That's a 14% increase in people who are now considered to have the condition of diabetes, based on the fact that consensus of experts shifted the threshold from 140 to 126. Of those 1.7 million people, the vast majority of them are going to have very mild, or would be classified as having very mild early diabetes, because their fasting sugars are somewhere between 126 and 140. Hypertension is a similar story. When we dropped the definition of hypertension from 160 over 100 to 140 over 190, there was a whopping 35% increase in patients who were labeled as hypertension. Now, many of those patients were put on diuretics or other pharmacologic therapy, many of which have pretty significant side effects. The third line is the same story with hyperlipidemia or increased cholesterol, and this one, the last two really are pretty amazing because it's an 86% increase in patients with hyperlipidemia and an 85% increase in women who have osteoporosis. Again, this is just based on shifting the threshold for disease. Now, I remind you, you've seen this chart before, but let's just bring it back for a moment because we want to say, why does this matter? Why is it important? If we look at the situation of diabetes, we are now looking at people who have a much earlier, milder form. We have already seen that the treatment benefit of people who have early, milder forms of disease is very small compared to the treatment benefit of people who have more severe disease. So what we're doing by shifting these thresholds down is we are, number one, increasing the number of people who are now considered sick or diseased or not healthy, but we are also increasing the number of people who are going to be treated for that disease with actually probably very limited benefit. All right, let's go on to the last topic related to laboratory testing and the topic of overdiagnosis. And this is a favorite of mine. I think this is fantastic because the American Board of Internal Medicine Foundation has created something called Choosing Wisely. And I highly recommend that if you haven't been to this website, you just Google Choosing Wisely and go to their website and just stroll around it. I have focused here only on laboratory medicine, but Choosing Wisely includes all medical specialties. As a matter of fact, it has 58 participating medical societies in it. So the American Society of Clinical Pathology, which is the laboratory medical society, is certainly represented, but you will find anesthesia and surgery and internal medicine and radiology on this side, and I cannot say enough good things about it. Choosing Wisely is a campaign which aims to promote conversations between clinicians and patients by helping patients choose care that is, number one, supported by evidence. It is not duplicative of other testing or procedures the patient may have already received, and most importantly, it's free from harm, and even more importantly, is truly necessary. The American Society of Clinical Pathologists, or ASCP, lists 10 tests you should always question if your physician orders this test. And I know some folks struggle with this, and I really want to encourage all of you that if you are seeing a medical provider and they order this test, you should have the conversation, and hopefully you visited the Choose Wisely website and you can go in with some information and just have a conversation about why does the clinician think that this test is necessary. This is the list of 10 things from the Choose Wisely website, the 10 laboratory tests you should always question. And I'm so glad vitamin D screening is on it because I myself have been screened for vitamin D deficiency, and guess what? I'm vitamin D deficient based on the cutoff. Now, that is not surprising to me because I work in the basement of JPS and I never get any sun unless I happen to go out and stroll around at lunchtime. So I'm not totally surprised that my vitamin D is low, but if I go on vacation to the Caribbean and I lay out in the sun for 2 weeks, my vitamin D level pops back pretty dramatically. So this is a great example of overdiagnosis. I'm being labeled as vitamin D deficient and being advised to take vitamin D supplements, but in fact, the vitamin D is not causing me any harm. It's not really a disease, it's really a condition, and is very unlikely to cause me long-term adverse effects based on my personal history. I do not have a history of osteoporosis in my family. I have women in my family who have lived a long time and never had any problems. So when you put all those things together, vitamin D screening is one of those things that I don't really need to do anymore. There's a lot of other ones on here that are really important. A thyroid panel, that's when you get more than one thyroid test, and T4, T3, TSH is the typical panel you will see. You don't need those tests. If your physician thinks you may have a thyroid problem, they only need to order TSH. Bleeding time is an archaic test that should never, ever be done anymore. Erythrocyte sedimentation rate, or ESR, is a test used to detect whether you have any inflammation in your body. That is an old, outmoded test. It literally takes a tube of blood and lets sit for 15 to 30 minutes and lets the blood sink. And depending on how far the blood sinks, we measure it on the test tube and we come up with an ESR. Not a very sophisticated test. There is a much more sophisticated test for inflammation now, and it's called CRP, or C-reactive protein. So you should never get an ESR. You should get a CRP if that's what you need. In the diagnosis of acute myocardial infarction, or AMI, or heart attack, myoglobin and CK-MB have no relevance, no purpose whatsoever. The only thing we do now for the diagnosis of a heart attack is a troponin level. Low-risk HPV should never be tested. It should only be high-risk. No one needs a vitamin K level, very similar to the vitamin D screening. STEP9 is actually fortunately gone out of fashion, but it is a test which purportedly detected colon cancer. It actually doesn't work. Don't use it. The NMR lipoprofile is something that is phasing out because actually the laboratory that did it was a proprietary laboratory that got into trouble with the federal government over compliance issues and had a massive fine and is now shut down. But NMR lipoprofile is they would give you this fractionated lipids. You don't need fractionated lipids. You need cholesterol, LDL, HDL. That's all you need. And then Helicobacter pylori by blood test is useless. The Helicobacter pylori should always be done by a breath test. So this is a really good example of 10 tests you should always question because they have absolutely limited to no clinical efficacy, which is a very polite way of saying they're essentially useless. All right, so in summary here, let me just really give you 5 take-home messages that I'd like you to walk away from this presentation with. How can you avoid overdiagnosis from laboratory tests? Well, first and foremost, use the Choose Wisely test list to question whether the test is useful and necessary. If it's on the Choose Wisely list, in all likelihood, it's probably not useful for you. I will caution you there are rare circumstances where specific vitamin D testing is necessary if you have chronic kidney disease. But the other tests on that list are really not particularly useful. I really encourage my clinician colleagues to limit the use of routine screening laboratory tests. I don't think there's a lot of usefulness for most of them. If you're a healthy individual, if you don't have signs of a disease or symptoms of a disease, if you are not at risk for disease, routine screening laboratory tests really have a fairly limited utility. That's not to say you should never do them. It's to say you should do them thoughtfully based on your history as an individual person, your past medical history, your family medical history. And I'm not sure that they're going to do a lot for you just routinely every year you go in and you get your 5 tests. I would caution against that kind of use. You should always question an abnormal screening test result that falls just outside of the normal reference range. Remember we said you could actually still be normal even though your lab report says you're abnormal. And the only way to do that is to have a discussion with your clinician or with your laboratory to find out whether or not your barely abnormal test could still potentially be within that 100% reference range and you didn't just get excluded because you were outside the bell curve. You should discuss whether a positive test result should be confirmed. If your physician is testing you for a disease that is considered uncommon or rare, in other words, it has a low prevalence in the population that you belong to, and you get a positive test result, you should always say to yourself, wait, does this have good positive predictive value? And you can go to your doc now and say that, and you can be really smart and say, what is the negative and positive predictive value of this test? Because maybe I should be confirming this test with a second test. And I would definitely recommend that for these when the disease is uncommon or rare. And finally, You should always have a discussion with your healthcare provider explaining the benefits and risks of all treatment strategies. If you fall into one of these categories where you are now considered abnormal or diseased because you've exceeded a threshold, you should always talk to the clinician about what is the potential benefit versus the risk of treatment. Because again, overdiagnosis is a problem because it leads to treatment which has the potential to cause harm. And with that, I'll turn it back to the moderator, Brian, to see if you have any questions we can entertain.
Well, thank you for that wonderful presentation, Dr. Miles. If you have any questions, go ahead and continue to write them into the chat box. I know there are a lot of comments and questions that were coming in during, so I'm just going to kind of run backwards through those. I see a comment here from Adela Justice. Thyroid panel, yes, ugh. We have a question from Bob Bartlett. Okay, so checking with the glucometer manufacturer, they claim that accuracy is plus or minus 20% in the middle range, worse at extremes, greater than 180 or less than 80. What's NIST doing?
Bob, that is a great question. NIST is currently not doing anything about glucometers that I'm aware of. For those in the audience that don't know what NIST is, it's a National Standards Institute that sets requirements for the performance of tests. Glucometers, you're absolutely right. I'm so glad you brought this up because this is a very hot topic right now. Glucometers, you're absolutely correct, have a 20% error rate. This is particularly true in hospitalized patients or patients who are critically ill. So what that means is if your glucose level is potentially, say you get a glucose level of 80, which most people would consider normal, the 20% error rate on a glucometer actually means that that result could be, let's see if I can do the math really quickly, it's 64 to 94, basically, somewhere around there. So once again, it speaks to the fact that the lab test is not an absolute number. The FDA is addressing this, not the NIST. The FDA has recently come out, I think it was in 2016, and stated that glucometers are no longer approved for use in critically ill patients in hospitals. So many hospitals are scrambling around to figure out how they're going to do glucose testing in the inpatient population. There is only one meter that is currently certified for use in a critically ill patient, and that is the Nova meter. Everybody else's meter should not be used in a critically ill patient. I should mention that if you're at home, these meters actually work really well at home. The 20% error rate is not for home use. It's for hospital use. The error rates at home are probably closer to 10%.
Okay, so someone just made a comment, the ECRI Institute tests glucometers and other devices for accuracy, and the URL was printed in the chat box there. Okay, so we had a bit of a conversation I'm going to go ahead and read out loud here that was kind of taking place over the course of the chat. We talked about ranges when I worked in, this is from Cecilia, we talked about ranges when I worked in healthcare informatics. I learned that not all ranges are equal across hospitals or even labs, from Heidi Sue Adams. Is this because of the testing equipment? What about reference values printed in reference sources like Henry's or other knowledge-based resources? I thought those were standards. Cecilia responded with, well, let's ask our presenter. I was using RELMA to map laboratory tests to the most likely LOINC.
Okay, great questions and a great discussion. Laboratory reference ranges are not the same from lab to lab. They are not the same from publication to publication, and there's very specific reasons for that. It is first and foremost related to the population search. For example, I work at JPS. That is a county hospital. So I have a patient demographic there that is very different from a private for-profit hospital in Fort Worth or Dallas or Greensboro, South Carolina, or anywhere else. So the patient population, first and foremost, determines the reference range. The second variable for reference range is the piece of equipment you're using in the laboratory. The equipment all has biases related to each other. So an 80 on one piece of equipment may give you a 96 on a different piece of equipment, and therefore the reference ranges have to be different. The published reference ranges that you see in any variety of resource book, Merck Manual, for example, those come from a variety of different sources. And again, it's dependent on the population tested and the methodology or the equipment used to get that range. So hopefully that answers your question about reference ranges. They are not all created equal. They're apples and oranges, and they cannot be universally applied.
Great. So we had a few more questions come up just now. I'm just gonna kind of pick from those. From Daniel Burgard, what is your outlook on whether overdiagnosis will lessen or grow given the sociocultural and economic factors at play in our current healthcare system?
Gosh, that's another fantastic question. I love that question. Unfortunately, I think that overdiagnosis will continue, which is why I think it's so important that we start having discussions around it. I'm very encouraged that I'm starting to see overdiagnosis in major medical journals, that there are a number of publications available now around it. I think that we as a society are becoming diseased. Almost everybody has something wrong with them. I mean, Gilbert Welch has a great introduction in his book about this, and I'll do it for myself. If I looked at myself, I'm a middle-aged female. I potentially have aches and pains in my joint when I go hiking with my husband, so I have osteoporosis. I've already told you I'm vitamin D deficient. I have occasionally some terrible heartburn when I go out and eat very spicy Mexican food. So perhaps I have gastroesophageal reflux disease. We are becoming a nation of diseased individuals. I think this will be a trend that is very, very difficult to turn. I think it requires a lot of conversation among ourselves, our healthcare providers, and just among our families, friends, and each other. We need to come to grips with the fact that not every abnormality constitutes a disease or a condition that A, requires treatment, B, will kill me, or C, cause me any harm in the future. And that's a tough conversation to have, but I think it's really important that we start considering this.
Related question earlier from Dr. Renee Hodgkins. Our health insurance gives us a discount if we do yearly health screening, including all the tests you just mentioned. Is overdiagnosis driven by health insurance assessing risk?
Yes, completely agree with that statement.
Great. So there's also another question that came in earlier from a participant. Experts like Durandar says the AD36 virus causes obesity. Where could someone be tested for this virus, or is it too expensive? The context is that hospitals say they cannot test me when I ask how much that test would cost. So the question is, where does she suggest people go to get an unusual lab test, like for virus 36? And has she heard of it being a causative factor in obesity?
I have not heard of it being a causative factor. That is a new one for me. I'd love to see that reference. That is not a test that is commercially available. What that means is it's a test that's a research test. Some researcher somewhere, CDC or somewhere else, has developed a test to detect the virus, but it is not available commercially to the general public in a laboratory. So your hospital laboratory is absolutely right. They don't have it available. I don't have it available for you, and it would be for research purposes only.
Great. I just want to read another comment from Julia Sparza. I was just having a discussion with a clinical faculty member about the fact that residents often have trouble thinking about testing appropriately. Specifically, ETD says, test this way for the person for surgery, but surgeons have said the patient is too frail to do surgery, but the residents still get the imaging. The critical thinking is hard for them to grasp, and they've been told so much to do X, Y, or Z through medical school.
Again, great comment. We are driving overdiagnosis by not educating our medical students and residents to the things I've just educated you about in this presentation. Most residents that I speak to, many of my attending medical staff, don't understand the limitations of screening tests. They don't understand prevalence, sensitivity, specificity, and it is really on educators and research personnel, librarians, to start providing this information to people so that they could begin to understand the limitations of testing.
Okay, great. Unfortunately, I know that there were several more questions that were in the chat box, and we'll collect those and go ahead and forward them to Dr. Miles, and she'll be happy to answer your questions offline. Thank you again for coming, Dr. Miles. It was a pleasure to have you with us. I am now going to go ahead and stop the recording. before a few final housekeeping items, so please don't take off yet.